Um, my name is Nhlanhla Shimange. I'm a pathologist from Lancet Laboratories. I'm a medical microbiologist. So Prof invited me to come discuss laboratory diagnosis of genital infections. So this presentation will mainly focus on the key laboratory methods for STI diagnosis. So we'll discuss microscopy culture and the more advanced techniques like your nucleic acid amplification testing. So STIs are a serious public health problem around the world, especially in sub-Saharan Africa. They affect sexual, reproductive, and overall health. Genital infections are caused by bacteria, viruses, or parasites. They mainly spread through sex, and they can pass on through blood and from mother to child. So STIs and HIV share a complex bi-directional relationship with STIs worsening HIV and HIV worsening STIs, and STIs predisposing patients to acquiring. So I'm not going to bore you with stats. I'm sure you know more about the statistics than I do, but we do have high rates of STIs in sub-Saharan Africa and high incidence. So this is a Sentinel evaluation that's done by NICD. So it's they analyze provincial reporting for STIs, and they found that the reporting compliance exceeded 70% in 7 of the 9 provinces. STI syndromes with the highest incidence were your urethritis and vaginal discharge syndromes. And this was mainly between the ages of 20 and 24 years. And overall STIs incidence were mainly in females. And we know this is usually due to reporting. So what are the commonest syndromes? So commonest syndromes is your vaginal discharge syndromes and your male urethritis syndrome and genital ulcer disease. So I'm going to focus more on vaginal discharge syndromes, and because male urethritis syndrome causes are similar. So if you talk about vaginal discharge syndrome, same causes as male urethritis syndrome, except for a few things that I will highlight. So vaginal discharge syndromes are mainly caused by Neisseria gonorrhea. So this is a gram-negative diplococci, chlamydia trachomatis. So this is a gram-negative organism, but it's usually doesn't have a cell wall, and it's difficult to culture this organism. Other causes include Gardnerella vaginalis, and which causes bacterial vaginosis, Candida species, so your Candida albicans mostly, and your non-albicans Candidas. Trichomonas vaginalis, which is a parasite, Mycoplasma genitalium, Uroplasma urolithicum, and other etiologies such as allergies and autoimmune diseases. So with your the common causes Neisseria, gonorrhea, and chlamydia trachomatis, it's usually difficult to culture them because your Neisseria gonorrhea is very fastidious. It requires an enriched media, but under microscopy we are able to see it, but sensitivity and specificity is very poor. Chlamydia trachomatis, we can't culture it. We need cell cultures to culture it. And so we usually recommend that you do a PCR for it. Gardnerella vaginalis and Candida species. And so we usually don't say they are sexually transmitted, and because females can get them without them being sexually transmitted. And then genital ulcer diseases, commonest causes are herpes simplex virus 1 and type 2. Treponema pallidum, which causes syphilis, and then other causes that are not common anymore include chlamydia trachomatis silvers L1 to L3, causing LGV, and then Haemophilus ducreyi, causing chancroid, and Klebsiella granulomatis, causing granuloma inguinale. So the commonest causes are the first two, herpes and treponema pallidum. So what are the challenges? So the challenges are the overlapping symptoms and signs. And so relying on symptoms and signs is not sensitive and not specific. Empiric treatment as well is raising a significant concern, and microbiologists like talking about antimicrobial resistance and the gut microbiome, and we are worried about antimicrobial resistance. That's why we are leaning towards testing. And then routine screening is inadequately implemented, and this increases morbidity. Untreated chlamydia and gonorrhea can lead to PID, infertility, and ectopic pregnancies. Untreated syphilis can complicate and with congenital syphilis, which we are seeing sort of like a resurgence in congenital syphilis, and CNS complications like your neurosyphilis. Viral STIs are often incurable and may reoccur. So diagnostic testing, so reasons we want to diagnose, obviously it's because we want to, because of the overlapping signs and symptoms, and we want to decrease the use of inappropriate antibiotics, decreasing antimicrobial resistance. And another thing is these are, some of these are notifiable medical conditions. Your ceftriaxone-resistant Neisseria gonorrhea is notifiable. Congenital syphilis and hepatitis B and C are notifiable medical conditions. So history is obviously important. There's the 5 Ps of sexual health. This is available on CDC. I'm not going to go through it. And then we come to laboratory diagnosis. So in the laboratory, we ask for swabs mainly and urine. So it's either you'll request for microscopy, culture, and sensitivity, or molecular panels. So I'll just go through all of them and tell you the advantages and disadvantages of all these diagnostics techniques that we have. So a sample comes to us, and it has to come as soon as possible because we have fastidious organisms such as your Neisseria gonorrhea. And when it gets to the laboratory, we'll do microscopy. And so we'll do a smear and look at these slides under microscopy. So what we mainly look for is Neisseria organisms and fungal elements. So Neisseria, and we'll see it under the microscope as gram-negative diplococci intracellularly. So these are your polymorphs, and you can see all these small organisms, they're diplococci intracellularly. So we know, and this is diagnostics and for Neisseria gonorrhea. But the problem with this is the sensitivity, especially in females, and is very low, but specificity is high. So sensitivity in males is high. And then other things that we are able to see under microscopy are your fungal elements. And so we'll see oval-shaped, round spherical staining gram-positive, sometimes staining gram-negative. So this is your fungal elements, and we'll be able to tell if this patient does have candidiasis. And then we are able to see through cells as well. So these are true cells, and this is your squamous epithelial, and with multiple bacteria clumping all together. And this does give you an indication that this could be your bacterial vaginosis. And then we are able to do a BV score as well. And so a BV score is a score and where we do a gram staining, and then we look for protective bacteria such as your lactobacillus, and we score those and from 1 to 4, and then we also look for pathogenic bacteria such as your mobilincus and such as your Bacteroides fragilis, your gram negatives. So what we want to see and to show that the patient has good bacteria, it's your lactobacillus, and so your gram positive bacillus. And then we add up that score, and then we'll give you a score from ranging from 0 to 10. And a score of 3 and below, it means the patient doesn't have a bacterial vaginosis, so they mostly have lactobacillus and which are protective. But a score from 7 to 10, a patient, it's indicative of bacterial vaginosis, so they mainly have your gram-negative organisms which are not protective and pathogenic. And then, so we comment on altered vaginal flora. So we can also see Trichomonas vaginalis and on the microscopy. And so this is your flagellate parasites, and that causes vaginal discharge syndrome. So this is what we see under the microscopy. So Trichomonas vaginalis. And then we'll be able to see whether it's observed or not observed. And we also do cultures. So cultures, the main thing that we're looking for is your candida, and candidas grow very well. So this is Candida albicans. And we can see Neisseria as well. This is Neisseria, but it's very fastidious, and sometimes you can't culture these organisms. That's why we always say we prefer a molecular testing, but culture has to be done as well. And for us, the only way we can do sensitivities is through a culture, and molecular assays don't do sensitivities. And your ceftriaxone resistant Neisseria gonorrhea is notifiable, and that's why we need culture. So moving on to molecular panels. So molecular panels, we can either do a single panels where we can test for Neisseria gonorrhea, or double panels where we can test for Neisseria gonorrhea and chlamydia trachomatis, or we can do syndromic panels, which I'll discuss later on. So what happens is we receive a sample, so a dry swab from the oropharyngeal, from urethra or high vaginal swabs, or urine as well, specifically from females, but even, from males, but even females, we do take urines. So what we do is we do nucleic acid extraction, and we do amplification. And so we have a specific primers, and that are specific for all those organisms. And we have nucleotides, laboratory nucleotides, and that will bind to that primer and extend whatever target that we are looking at. So molecular assays will go through denaturing, annealing, primer and anneals, and then extension. So we'll repeat the cycle 40 times, and we are able to detect and analyze the results, and it will tell you whether it's positive or it's negative based on the number of amplicons that are available. If there's no amplicons, nothing amplified, then that will be negative. So multiplex syndromic panels. So we love these, and because it's difficult to tell whether the patient has Neisseria gonorrhea or chlamydia trachomatis, they have trachomatis vaginalis. Multiplex panels allow you to diagnose a syndrome. For example, if you think a patient has meningitis, you just say, okay, patient has meningitis, send us a CSF, and we're able to test all the commonest causes of meningitis, similar to gastroenteritis, similar to vaginal discharge syndromes, genital ulcer diseases. So we test for the most likely causes of that specific syndrome that you have diagnosed. So you send us one sample, one test, and you get multiple results. If the patient has a dual infection, we'll be able to tell you that the patient has a dual infection with Neisseria gonorrhea plus chlamydia trachomatis. And as soon as the sample gets to the laboratory, and we're able to give you a result within an hour or so. So why do we love the multiplex syndromic panels? So there's reduced need and for multiple sample collection. They simplify the testing algorithm. They simplify testing and laboratory workflow, reduce time to results, and as opposed to your cultures. So your cultures will take, if you're lucky, 48 hours, but at most around 72 hours. And because you have to do culture, you have to culture and wait for the organism to grow. And as opposed to your molecular panels where you just need a genetic material and we're able to detect it as soon as possible. It allows testing for pathogens that are not detected by conventional methods. So your chlamydia trachomatis, we can't culture those. And so if you send for culture, we won't be able to tell you whether the patient has that or not. Your viruses as well, such as HSV, improved sensitivity to over many conventional methods. And so they're highly sensitive as compared to your cultures. And they promote antimicrobial stewardship as well. And so we're able to tell you this patient has this. You can use ceftriaxone and for Neisseria gonorrhea instead of using ceftriaxone and azithromycin. So which panels do we have in private? So in private, we have multiple panels. And so we have a vaginal discharge syndrome panel. And this tests for urethritis as well. So it's a multiplex panel. We're able to detect Neisseria gonorrhea, chlamydia trachomatis, Mycoplasma hominis, Mycoplasma genitalium, Trichomonas vaginalis, Uroplasma parvum, Uroplasma urolithicum. And if you look at these, and all these organisms are difficult to culture. We can culture Neisseria gonorrhea, but it's fastidious. Chlamydia, we can't culture, and because it's difficult to culture it, and mainly because it doesn't have a cell wall. And then Uroplasma urolithicum, we can't culture it. Trichomonas vaginalis is a parasite, and we can't culture it. So the samples, it's swab, dry swab. So you can swab oropharyngeal, rectal swabs, and you can swab high vaginal swabs, urine as well, and then fluid. And so this is mainly if there is joint infection, be transported to the relevant laboratories. But as soon as it gets to the laboratory, turnaround time is around an hour. And then we have dual panels, chlamydia and gonorrhea panel, and because we know these are the commonest causes of vaginal discharge syndrome. So samples are the same, turnaround time, 24 hours. And then genital ulcer panel, we test for herpes simplex virus type 1 and type 2. And then we test for Treponema pallidum, and which are the commonest causes of genital ulcers. But we also test for other causes that are not that common anymore. And so we're able to test for Haemophilus ducreyi as well, and cytomegaloviruses and varicella zoster viruses as well. So with genital ulcer panels, and you only need to swab and the lesions if there is a lesion, or send us tissue or urine as well. So other things that you need to consider as well is additional testing. And so additional testing for herpes simplex, you can do herpes simplex serology, you can do IgG and IgM. So IgM is not reliable because it cross-reacts with other DNA viruses. And so you might get an IgM that's positive, but this is due to varicella zoster virus or CMV virus. IgG is more reliable, but it won't tell you, but it's not going to help you and say this is a current infection, but it does tell you this patient has had an infection and with herpes simplex virus. And then serology for syphilis is very important as well. And so especially and with genital ulcer disease, you need serology and for syphilis because the PCR is not sensitive, is not sensitive unless you have a primary chancre. And that's when the PCR sensitivity goes to up until 90%. But otherwise in blood, and if you are worried about syphilis and in blood, sensitivity is very low. So we don't recommend you do PCR for syphilis. So we like nucleic acid amplification tests, and because studies have shown that These have increased sensitivity and a good specificity. So they did multiple studies, and they saw that if you only do a culture and you miss even 50% of your positive Neisseria and chlamydia trachomatis, and so cultures sensitivity is low, but we still do say do a culture, and because these panels, we don't have chlamydia, we don't have candida, and for these panels, in case you want to see whether there's candida, and we can't do sensitivities, and unfortunately, and with molecular panels, and we do need to, with the rising ceftriaxone resistance and with gonorrhea, and we do need to do surveillance and see, and if we are seeing that as well. So we have other specific panels, and so we have a panel for chlamydia trachomatis alone, and then we have panel for Trichomonas vaginalis alone. We have herpes simplex PCR, we have varicella zoster PCR, and we have monkeypox and PCR as well. And then other panels include human papilloma virus panels. And so we have panel that tests for high risk human papilloma viruses, and so 16 and 18, and other high risk types. And then we have a human papilloma virus PCR that tests for 37 low and high risk types. So these are usually the ones that we will recommend for males, and if they are worried about infection with HPV in males. But for females, we usually recommend that you do HPV 16 and 18. So a word on syphilis. So syphilis is, we're getting more and more syphilis in the public sector, even congenital syphilis as well, and in the public sector. So the theories are maybe there's a decreased use in barrier methods. We don't know whether even PrEP could be driving this, and because people feel unprotected. And then the use of things like your azithromycin, doxycycline as well. And so sometimes it's not easy to get these typical signs and symptoms of syphilis, and patients present late. And then we are seeing increased rates of congenital syphilis. So screening is recommended, especially in pregnant women, early in pregnancy, and screening and for syphilis. And then in late pregnancy as well, if you are worried, and screen for syphilis. So congenital syphilis is a category 2 notifiable medical condition. So we always have to screen these females. So how do we diagnose syphilis? So we have specific treponemal antibodies and non-specific treponemal antibodies. So what we do in private is we do the reverse algorithm as opposed to the normal algorithm where you had to do RPR. If RPR is positive, then you do your specific treponemal antibodies. So we use a specific treponemal antibodies, and because number one, we are a high throughput lab. Number two, the sensitivity is very high, especially in early syphilis, and also in early latent syphilis, where your RPR, and which is not specific, has a lower, it can be negative, and then you miss those patients. So what we do is we do ELISAs, and so it detects both IgG and IgM. So ELISAs and these specific treponemal antibodies won't be able to tell you that this patient has a current infection or it's a past infection, because we don't differentiate whether it's an IgG or an IgM. And number two, they remain positive lifelong. And so you can get a patient with a positive ELISA, but this patient has been treated before, but it's still positive. And so every time we get a positive IgG, IgM ELISA, we have to do an RPR. So in RPR, if it's positive, you know this is an active disease. And it also helps us follow up these patients. And so disease progression, if you're treating this patient, you want the RPR and to decrease by fourfold. And so we have to do the RPR. So other things you need to consider is offer HIV testing, offer hepatitis B and C testing. In all these patients, whether they come with vaginal discharge syndrome or whether they come with vaginal genital ulcer disease, you have to offer additional HIV, hepatitis B and C, syphilis, and cervical cancer screening. And then also offer testing as well. So in conclusion, this is a serious public health issue. The World Health Organization aims to decrease STIs and to less than 150 million by 2030. Clinicians and health systems beyond traditional STI services should be included in STI care. So the problem is we leave STI care to gynecologists or to urologists, and when these patients go to for other care, no one asks about their sexual health, and it should be a part and parcel of the healthcare system. So syndromic assessment yields poor sensitivity and specificity for correct diagnosis. Laboratory diagnosis is a key to bridging this gap. Managing appropriate and directed therapy is an important strategy for antimicrobial stewardship and for decreasing antimicrobial resistance. And then consult the microbiologist before collecting samples and ask about the tests that they have, and so they can advise appropriately. Thank you.
Thank you, Doc. I'm so sorry. I had a situation this morning, so even my phone had a situation. And thank you for arranging. We have an online audience. I don't know if I've got a few questions, but let's just anyone hearing the floor? Dr. Sean? Dr. Manson.
Yeah, just a few practical questions. So it seems that there's a discrepancy between what is possible and what is actually available. Could you maybe talk us through the barriers to that PCR testing in state? I mean, is it in any way feasible? Is it on the horizon for state patients? And also just allied to that, the swabs, because it would appear that if we're going to ask for culture, we need to send a swab which is suitable for culture. But if for PCR, it's actually a different swab, a dry swab.
Different swab, yeah.
So maybe you can just talk us through that.
So unfortunately,
Just because the mark again.
oh, sorry.
For the online.
So unfortunately, these tests are very expensive. So I can give you an example with the genital ulcer syndromic panel. So this is almost 3,000 rands. And the government, according to the Bill of Rights law, and they do need to provide emergency care for every patient, but this is not an emergency thing. So that's why they came up with syndromic management. These tests are very expensive. And so I don't think they will be available in government. So the only places where I know, and we do PCRs, and it's PCRs for Neisseria gonorrhea and chlamydia. And so in tertiary hospitals. And so I trained in Steve Biko. And so we do have PCR for chlamydia and gonorrhea, but the whole multiplex panel, and it's not feasible, and because they are very expensive. And then with regards to sampling, yes, and unfortunately we need 2 different samples, and because with your gel swab, and that's the one that we normally use, and for culture, and only because they preserve that organism and we want those organisms to grow. So that's the one that we use for culture, the gel swabs, because if you use a dry swab, those organisms die. But the dry swab is fine, and because we're only looking for the genetic material. So whether the organism is viable or not and doesn't really matter. So the reason we can't use the gel swab for your molecular assays is because those gel swabs have inhibitors, and we use them, the results are invalid or they come back as false negatives, and because of inhibitors in the gel.
So basically, I think just following up on Dr. Mo,
Mhm.
if I'm a clinician and working in state like I think most of the audience is, and I'm interested in identifying an STI, we should not be using the gel swabs, because a lot of times especially in pregnancy, somebody comes with PPROM or discharge, what we have is the gel swabs. Very rarely do we have the dry one. And you are saying that the dry one is the right one for your amplification.
So the dry one is the right sample for your PCRs and for the PCRs, but the gel one is the right sample for your culture. But in state, and so in state they have gel swabs, and because state has cultures. As far as I'm not sure about Albert Lutuli, but as far as I know, NHLS PCRs are only available and in specific tertiary institutions. And so when I was training in CBICO, it was also difficult to get PCR molecular assays, and it will just be when you are asking for a favor and the clinicians are sure this patient has an STI and we haven't grown anything. So we have laboratory derived tests that are verified and validated in the laboratory and they're not commercially available. Sometimes we would send those samples to NICD as well and for molecular assays. And so in state, as far as I left state in 2021. So, but as far as I know, they don't have any molecular assays for STIs. So that's why you always use a dry swab, because they do cultures.
Now, you're using of words, you're using nuclear multiplication, multiplex, PCR. Can we just, we are gynaes. I know I'm the prof here, but I'm confused.
Yeah.
And I guess a lot of my people are as well. So
Yeah.
be specific as to what is it you are talking about. Do we have a multiplex platform in state? I know you have it in private.
In private, yeah. Okay. So multiplex, so there's molecular assays that look for genetic material, so RNA or DNA. So these molecular assays, they use nucleic acid amplifications, and so polymerase chain reactions. And so what they do is, it doesn't matter whether the organism is alive or dead, and there is a genetic material. And so we have specific primers that are specific for that genetic material that we have extracted, and they'll be able to amplify that genetic material multiple times to a level where we are able to detect it on our machines. This is positive. And this,
that process the same as multiplex.
Yeah, so multiplex, it's the same process, but with multiplex you have multiple targets, and so you have multiple extractions and of different organisms happening at the same time in one. And so, so say this patient has a vaginal discharge syndrome. I don't even, not that, yeah, I don't even want to know, and I don't even want to stress about what is causing this, but I know the commonest causes are these. And so there is a test that can cause a test for all the commonest causes. So what happens is we get one sample, and we don't ask for multiple samples, as opposed to maybe you want to do like syphilis or something else. So we get one sample. From that one, we're able to do multiple extractions. So our reagents, and is specific to those organisms. So if you have Neisseria gonorrhea, and we will be able to detect Neisseria gonorrhea. If you have chlamydia trachomatis, and because the reagents that we are using have primer specific for all those organisms, we will be able to detect this is a Trichomonas vaginalis. And if there's, for example, herpes simplex or syphilis, we'll be able to detect that as well. And so those are multiplex and panel. So singleplex, you are looking for one. And so whatever reagents we have are specific for Neisseria gonorrhea, multiplex, they are specific for all those commonest causes of vaginal discharge syndrome. So we have those, so we have even for meningitis, for gastroenteritis, for respiratory tract infection, upper respiratory tract infection, for lower respiratory tract infection. All we need to know is what are the commonest causes of this syndrome, and the reagents have primers and that are specific for that syndrome. So whatever your patient has, we will be able to detect that syndrome if the patient has whatever, if it is positive, but if it's negative, then you have to go and look for other things.
I'll give others a chance. I still have a lot of issues, Dr. Maise, and then Habinez time.
Yeah, my question is, when it comes to genital, to discharge syndrome, you are saying the microbiologists are concerned about resistance. Then I'm asking myself now, if they are concerned about it, what are we supposed to be doing? Because unless you can culture and then do sensitivity testing, just the mere identification does not deal with the resistance. And if you talking your PCR is not addressing sensitivity to antimicrobials, it's just identifying. Now, again, if you say, oh, clinically, your sensitivity of picking up the problem is low, the only reason I'll do a swab is if clinically I'm suspecting the problem. If I don't clinically suspect the problem, then we do a swab. So it's, to me, it's some bit of redundant. Sure, how, but so what I wanted to know is, because culture and Neisseria is the notorious organism here, and we keep changing the antimicrobial over and over. Where are you getting these cultures from? Is it from the males or from where? Because I mean, from the females, they're doing swabs. In terms of where, how are you able to tell us now? Now is resistant to this or this antimicrobial. Where are you getting these cultures from? That was my first question. The second one was going to be on the syphilis. You touched on it, and our ears were raised and our eyes were raised, because what we are seeing currently is the research, as you say, the problem is this titers or titers or titers, whichever way you want to say it. A patient has got a titer 1 in 32. You give them full treatment, but the titer does not make any fall after the 3 months that we are asked to test. It's still more or less the same. You're asking yourself, is it a reinfection or is there a phenomenon? I think there was a phenomenon that was mentioned. I think it goes with patients with HIV, where the titer often respond. Maybe you could comment on that one. So first, on this culture stories, and obviously the antimicrobial resistance and sensitivity, where you getting the culture from? Is it from the STD clinic, or where are you getting that from? And then second, this titers of syphilis story.
So, cultures, we do cultures and we do see Neisseria gonorrhea. So the problem is, and when these cultures are done, cultures are left in the ward, they're not brought to the lab as soon as possible. And so that's the problem that we are seeing from the laboratory, because we always say in the laboratory, so diagnostic stewardship is very important. And so if you give us, we always say it's rubbish in, rubbish out. And if you give us a sample and it was in there for such a long time, and Neisseria gonorrhea is very fastidious, we're not going to grow anything. And that's what we are seeing. With some clinician, and because they know there is a problem with Neisseria gonorrhea, it's fastidious. It's a fastidious organism. What they do is they even ask for a plate, and as soon as they swab the patient and they plate it out on the plate, on the chalk plate agar, and then send it to the lab as soon as possible. So we do see Neisseria gonorrhea, and we do see positive cultures, but what we are saying is the sensitivity is low. And so from the ones that we see, we are able to see them. And as soon as we grow them in the laboratory, and because we know the environment where this organism should grow. As soon as we grow them, we do sensitivities. And this information, it's fed to NICD. And that's why NICD will tell you and how many, that's why it's a notifiable medical condition. If we have a resistant gonorrhea, and they will and pick it up, and even on our system, and our systems are linked. And so Neisseria, it doesn't mean Neisseria doesn't grow. It does grow. And the problem is how it's how we collect the samples and how we leave them in the ward as well. But with PCR and the sensitivity is because it doesn't matter whether it's alive or dead, and it is there. And the reason we always say and send a culture, and we know the best test is a PCR and to pick up and treat a patient. But send a culture, and because we need to do surveillance and we need to see and whether we are seeing ceftriaxone resistant Neisseria. The only reason we stopped using ciprofloxacin and is because someone was doing these cultures, someone was doing sensitivity, and that's the only way we were able to see that ciprofloxacin doesn't work anymore. Unless if we stop doing cultures, we are going to go on with patients that are on ceftriaxone but they're not responding to treatment, and we won't be able to decrease the incidence of STIs. So yeah, so cultures need to be done, and we can't stop with the PCR. So with the PCR, and because of what we have, the data that we have already, and we know if the PCR is positive, we hardly ever see ceftriaxone resistant Neisseria, and in South Africa, I'm yet to see one as well. But we know in Southeast Asia, and they are seeing them in America, are seeing them. So, if we get a PCR, a culture is negative, at least there is data, and we can still treat these patients with ceftriaxone. We know we haven't seen this in South Africa. But if we all stop doing cultures, and we're not going to be able to know whether we are getting a resistant Neisseria gonorrhea. So it's not redundant. We need cultures. That's how we do surveillance in the laboratory. And PCRs, we know we love them, but the issue with PCRs is we are not yet able to detect, because with PCR, you can do sequencing and detect a certain gene that will tell you that there is a mutation on GRYA, and meaning you won't be able to use certain antibiotics. But we are not able to do that as yet. Some areas, they can do sequencing, and they get their and they get these Neisserias, and then they can do sequencing, and then they can compare them to the reference, and they can tell you there's a mutation at this and this and this. This will most likely be resistant to your ciprofloxacin or your ceftriaxone. But in South Africa, and we're not yet there, and even in the first world, they don't do that for patients. They do that for surveillance. And then with regards to syphilis, so syphilis,
By the titer.
oh, so the titers. And so with regards to syphilis, there's something that's called serofast. And so serofast is if you're treating a patient and the titers don't go below 1:8. So if they don't go below 1:8, and we know if the patient is fine, and we know, and this could be because they are serofast, because there is a percentage of those patients that you will never get your RPR and to go below that. But with that being said, and be aware that those patients could have neurosyphilis. And so they could have neurosyphilis, and we haven't treated the neurosyphilis, and that titer stays high. So that's why there's a recommendation that if you have a titers of 1:32, even if there's no signs and symptoms of neurosyphilis, you are advised to check for neurosyphilis, and if you are able to do that, and so because they are managed differently. So with those patients, if you are worried and you're treating a patient and titers are still high and they're not going down, look for neurosyphilis. Most of the times it's because the patient has neurosyphilis, and you can get neurosyphilis at any stage of syphilis. And so even if it's primary, it's secondary, it's tertiary, if your titers are not going down, look for neurosyphilis. It's most likely that, or they are a serofast patient, and you do get a percentage of those patients. But the titers are usually at 1:8. They're not on 1:32 or higher than 1:8.
When you say neuroceptics, you mean lumbar puncture?
Lumbar puncture.
So I'm still coming back to this, to simplify clinical approach. Your best advice would be, if we are, right now we know that we are supposed to treat syndromically.
Yeah.
Everybody's convinced that it might not be the best way, but it's a compromise.
It's a compromise.
So we are happy that it's a compromise.
We
will treat, and at the point where we feel like we are stuck,
that's
when we will do the culture. So now your advice is that when we do the culture, we do run and then gel one. Would you say that? Would you say I should take both, so that at some point you should be able to culture, at some point you should be able to amplify? That's one. Number two, how soon should I send my sample? How you said I mustn't wait for the porter to fetch it and blah, blah. How soon should the sample reach the lab in the best optimum of times? So those are my main questions. Which swabs, if I'm in that, not that everybody's going to be swabbing, but if I was going to swab, what should I take? How soon should I? Any special transport instructions? Give us that algorithm of some sort to see what should we be doing.
So unfortunately in public, and that's the compromise that we've reached, that we're going to treat syndromically. But if you have a patient who's not responding and you have to do cultures, and if they're not responding and you can't culture anything, and maybe you have to discuss with the local microbiologist, and they can arrange maybe with NICD if they don't have any panel, because NICD does have these panels, and to send a dry swab. So with a culture, and it's a gel swab, but with PCR, it's a dry swab. So with a culture, after swabbing the patient, the swab has to be in the lab as soon as possible, and as soon as possible. How soon, I don't know, but we know that it's a fastidious organism. Some clinicians even ask for a plate, and because Haemophilus, Neisseria gonorrhea and is fastidious, it doesn't even grow on our standard blood plate. It requires a chocolate agar, and that is supplemented with different things. And so they ask for that, and because as soon as they plate it out and they swab on the plate, at least, and it does get whatever nutrients and it needs, and it does reach the laboratory. And so we always say, when you take a sample, I know it's not an ideal world, and it should go to the laboratory as soon as possible, especially if you know fastidious things. And so it's like entamuba histolytica. And we always say, if you want to see tropozoids and if you want to see entamuba histolytica, you have to collect your sample, run with it to the laboratory. But otherwise, if it stays there for a long time, it's just going to die. For how long does it survive Neisseria gonorrhea? I can't tell you that. I have no idea. But as soon as, if you are suspecting that,
John?
Hi, good morning, Prof. Good morning, Dr. Shimange. Thank you very much for an excellent presentation. I hope you can hear me. I just have clarification question, please. So let me start with the NAAT test. I need to understand. Let's say, for example, if I'm requesting a chlamydia or Neisseria gonorrhea NET test, are you telling me that once you are detected that there is a presence of chlamydia or a presence of chlamydia on gonorrhea, so with chlamydia, you will not be able to do the next step, where with chlamydia, this gonorrhea is sensitive to. So you're telling me that the NET test that you're going to do is simply to identify the presence of the organism. It will not be able to do the next step, which is to indicate that it is sensitive to your mostly or your primary antibiotic of choice for this organism. Can you just clarify, just because then the next step would be, question would be, if it does, would the multiplex panel also do the same thing or not? Thank you. If you can just clarify that question, then I think I just have one more question.
But that was answered.
That was answered already.
John, that question was answered. Go on to the next one.
Oh, the next, yeah. So she said, my answer of that, my understanding that's why I still needed clarification, because my understanding when she answered Dr. Maese was the answer to that is no. So basically you are testing for the present, but you're still not going to be able to know that your treatment is going to work. So yes. I'm just again wondering why are we then doing it if it's costing 3,000 rand. So just, yeah. So then, yeah. I don't know whether and then should ask the next one, because my next question was, what's the cost for this? The net test for gonorrhea and chlamydia, because I had the multiplex of 3,000, but what is the cost for the gonorrhea and chlamydia, just those individual ones?
Okay, so molecular assays, you won't get any sensitivities, unfortunately. The only way, and you can get sensitivities, which we don't do, it's in research laboratories. And so research laboratories will map up the whole gene and then compare it to the reference strain, and they will know whether there's or not, and on whatever they've mapped out, comparing to the reference strain. So that is how they can do that. That is how they can tell you, and that this, and because if you, let me give you an example with fluoroquinolones, and we have a GRA gene, GRA gene A and B. We know if there's a mutation there, your fluoroquinolones will not work. And so same with all the antibiotics. And antibiotics, we know if there's a mutation or if there's a beta-lactamase production, and certain antibiotics will not work. And so that's how they're able to tell you that, okay, we've mapped out chlamydia. We know you can't culture them, but they can culture them also on cell cultures, but we can't do that. We mapped out chlamydia, and it has this specific gene, and this antibiotic will not work anymore. They do cultures as well, and where they use tissue cultures, and it's not the cultures that we use on the plates. And then they subject the chlamydia to certain antibiotics. And if that chlamydia survives, and they will tell you that this chlamydia will not, doxycycline or azithromycin will not work against this chlamydia. So that's why they have all these data. But the only laboratories that can do that is laboratories like NICD. It's research laboratories, and we can't do that. And so with our molecular assays, we don't have sensitivities. We can't give you the senses, but you have to do them because we are missing. We definitely can't tell you there's chlamydia and with cultures, and so we will miss chlamydia. And even if we don't grow anything, not because of gonorrhea, and it's because of chlamydia, we won't be able, there's no culture that we can do to tell this chlamydia. That's why you do need a molecular assay. Other things are like your uroplasma, urolithicum, mycoplasma, genitalium. We can't culture them as well. You need a molecular assay. And then with regards to the prices, so the prices for your gonorrhea and chlamydia, it's around 1.5 thousand rands. It is expensive, unfortunately. With your vaginal discharge syndromes, and where you have 5-6 targets, and it is around 2,000, your 2005, your genital ulcer disease, and it's a bit expensive. It's more expensive than your vaginal discharge syndromes. And then we also have a sexual health a package that we do, and to decrease the costs. But even that is expensive, and because it's almost 4,000 rands. And so these things are available only in private. So I don't know if that answers.
Yes. One last point. Oh, okay, Dr.
So you said for genital ulcers, the best thing is to swab or urine?
So for genital ulcers, the best thing is to swab the ulcer itself, and so to swab the lesion. And if it's a vesicle, just swab the vesicle. If it's an ulcer, that's swab the ulcer. That's where your organism is concentrated.
Here you're referring only to syphilis and
Herpes.
herpes, yeah.
only those two.
No, even if you have your Haemophilus ducrei, and because you have, it's a genital ulcer, yeah, if you have your chancroid and an ulcer, then you swab the ulcer. Yeah, monkeypox as well, you swab the lesion.
My question was on sensitivity. So you
Mm.
mentioned that when we swab a female versus a male, it's less sensitive. Any reason for that? That's one. And then just talk a bit about the point of care diagnostics. Is it also giving you a panel, or is it individuals, and how sensitive are they?
Mm.
And are they available? I know we're talking private.
So with vaginal discharge syndrome and male urethritis, so I'm not sure as to why, and they have found that, and with males, and the sensitivity is high, and with your swabs. I don't know if it's maybe a technique, and because with the vaginal, it's with females, it's easy, and it's the urethra, and that's where everything comes out from. And with vagina, you have to be very particular on how you are swabbing. And so that could be swabbing, maybe it's the way we swab. And then with urine as well, same thing. And with females, and urine is not reliable because that's not where and you expect to find your gonorrhea. But with males, and everything else comes out from the same area. Yeah. Yeah.
With that, I think Neisseria and chlamydia, we say they cause mainly cervicitis and going up.
Yeah.
Now, if you are just going to take a vaginal swab, which is low down, I think maybe it makes sense.
Yeah. And then, point of care testing. And so we don't do point of care testing, but I know it is available. And NHLS does do, I think they have the syphilis and the HIV testing. So the main reason we don't do point of care testing is because of quality assurance, quality control. We don't know how to, even in the point of care, the problem has always been quality, and we're not able to assure and good quality and with these and tests. And so in the laboratory, we have things like National Quality Assurance System, where a sample is sent to all these laboratories, and we have to get a certain result. And so your laboratory has to get the same result as a lab in the United Kingdom. Otherwise, if you don't get the same result, then there's it's not reliable. The method that you are using is not reliable. So we always get samples, and we test, and we give them back the results, and then they'll give us back the answer and say, yes, and you got it correct. And then compared to this and this and this lab, how many labs got it correct? How many labs didn't get it correct? And so this is how we can assure our clients that we are a good quality laboratory. But if it's point of care testing, and I mean, how do you control that? How do you guarantee quality with point of care testing?
But are they there? My question is, are they there, and for which organisms, and have they been tested and validated?
So in private, we don't have them, but I know, and in in other countries in Africa, and they do use point of care testing. They have test enzyme assays, immunoassays for lateral flow assays for gonorrhea, for chlamydia, but even in those areas, and they do say that the quality assurance is a problem. So another thing with for example, we have congenital. We have tests for syphilis and HIV in the government sector. They are having issues with some false negatives. I don't want to say much, but there are issues with false negatives, and that were being discussed, and with syphilis, and that's why we are worried that we're seeing a resurgence in syphilis. I don't know if you do have discussions with your pediatricians, and if they are seeing a resurgence with syphilis, but Prince M, and they see a case of congenital syphilis almost every month, and which is shocking because the last time I saw a congenital syphilis case was when I was doing pediatrics. And so we don't know how reliable these tests are. And because some of these patients were tested and it comes back as negative. And so point of care testing is not reliable. It is reliable, but it's not the best thing. So in private, and because quality is very important in private, we don't do point of care testing.
The reason I'm asking, I'm not so much asking about HIV and RPR. We do them with our backbone. If we throw them out of the window, then our service is really compromised. I'm talking about the point of care testing for STIs, chlamydia, because there are drug companies now that are pushing them. And you know, there's a big noise right now going on in the STI world that says we shouldn't be going syndromic. We are compromising the patient. We're ending up with a high rate of PID because we are missing. So we should be pushing individual, you know, your multiplex, your multiple testing that have now been reduced to the point that you don't even need the lab. You can actually do where you are, do them as a point of test. That's why I was asking, because the drug companies are pushing them. I don't want to call them drug companies, but the companies.
But the question is, how do they ensure quality?
I'm sure they are out there because they've been tested. Just like, you know, I'm sure there is a give and take. Anyway, I haven't read a lot about them, but I know that they are there. And go to conferences, you see the rep there pushing and saying we can test this for your patients and what. And, yeah.
My take on that is, and there's certain things that you do not want to gamble with, and that's why. Okay, so the other thing with point of care tests, the storage. Or if you go to places where they do point of care testing, most of the times even the storage is not correct, and they're not. So the test can be validated, and so the test can be validated against FDI and FDA methods, and FDA can approve it and say, okay, this test is good and to go commercially. But there has to be verification first, and to make sure that the test works there, and then there also has to be a continuous validation that this test that we said works and is still working and we said it works. And the only way you can do that is quarterly or monthly, and you do quality assessment, you do internal controls, and you do quality assurance. But these point of care tests, they give you a batch of tests, and then you use those tests and without continuously checking whether they are still working or not. So a batch can, but one test is not the same as the other tests. But what we do is with our platforms, and so for example, with our vaginal discharge, with the multiplex platforms, and we get sent samples with known results all the time. And then when we get sent those samples, we have to test them all the time. So we always test them. We continuously test them to make sure that they are still working as we said they are still working. But with point of care testing, it's not possible and to assure that the test that you bought last month is still working as you said it is still working. So unfortunately, and in public sector, we do compromise quality and in public sector because of the finances, and we don't have things that they have in the private sector. And private sector, and if you talk to the microbiologists in public sector, they would love to have the things that we have in private sector, but they don't have the same access to the things that we have. And so they will resolve to using point of care testing and to using what is available, and which is also okay because we can't just throw away and what we have available and for something that we don't have available. And so, yeah.
Just a last one. If a patient with vaginal discharge syndrome, she's received ceftriaxone, she's received azithromycin or doxycycline, she's received metronidazole, and you say send the specimen to the lab. What is the lab going to tell me that is going to deal with the vaginal? Is there other antimicrobial that I'm going to use in this situation that were not covered by these that I gave?
Okay, so if the patient has vaginal discharge syndrome and you've given her ceftriaxone, azithromycin, doxycycline,
Azithromycin, and I mean, the last one was obviously the metronidazole. Obviously, is ceftriaxone, either doxycycline or azithromycin, because you can't use both. And then you've given a metronidazole, which is obviously for the anaerobes and also for the other one,
BV.
BV, and also the
Trichomonas. Yeah.
Right. So the ceftriaxone was for the Neisseria. The doxycycline or the azithromycin was for the chlamydia and whatever the story is. And the metronidazole was for the anaerobes and the trichomonas and the BV. If I send the specimen to the lab because the patient is not responding, what is the lab going to tell me that would change the outcome?
So if you send a sample to the lab and you still pick up those organisms, and it's either the patient, and okay, we'll assume that the patient is taking treatment, okay, or she's getting reinfected, or you are dealing with a resistant organism. And so it helps you because, I mean, you can't keep giving antibiotics and you don't know what you're dealing with. Ne? It's better to say, okay, I've tested and there's nothing, and maybe it's something else, and maybe it's not infectious, and maybe it's I mean, okay, I'm guessing you have treated for candidiasis as well, and at that stage, but it gives you, I mean, and you're a step forward and to knowing and what is causing or not causing and whatever you are treating. And rather than you keep giving antibiotics and patients keeps coming back with the same thing, wouldn't you rather have a test and it's negative and you know this is not what I'm dealing with, and then you can explore other possible causes? And for me, and I would rather know if I am able to do a PCR, and for me personally, and if I had a vaginal discharge syndrome and I was able to do a PCR, that is what I would do, and before receiving all these other antibiotics.
Obviously, if you were to do the PCR and you find the chlamydia or whatever the story that you find the trichomonas, you find Neisseria will be slightly different. What is the alternative antimicrobials for this patient where we say she's not responding to conventional? Is there alternatives?
So you explore other issues and you explore whether are they really taking the antibiotics and whatever you're giving them, and you explore, and are they not really getting reinfected anymore? And then you explore, and maybe this is one of those and weird cases that maybe this patient might need a bit of prolonged treatment, and maybe they are very immunocompromised, and because it's not just antibiotics, and we give antibiotics and then we also have an immune response, but in patients that are immunocompromised, and we do say treat, and this is how you treat, but you are allowed to individualize the patient as well and see, and if really I am sure this patient is taking this antibiotic, then now, and we are heading towards, okay, is this a resistant, and is this gonorrhea resistant, and I'm giving the patient ceftriaxone, I've given 500, or I've given a gram if the patient is obese and they're not responding. Am I dealing with resistance? And if you have to be sure that the patient is taking and they're not getting reinfected. And if you are dealing with it, that's when you can communicate with an ICD and ask them, and I might be dealing with something that's resistant to ceftriaxone. And can we do something? And can you maybe sequence this for me and check if I am dealing with that? And if they are able to culture, can you do further antimicrobial testing for me to see and if this is resistant to ceftriaxone? Yeah.
Any hands? I think, thanks so much, Dr. Shimangi. I think we're also a bit out of time. Thanks for availing yourself.
Thank you.
Thank you.
Recording stopped.